Okay, good afternoon, everyone. From my side, welcome to today's webinar where we'll be talking about Mycosis Fungoides. And we have our speakers, Dr. Trilokraj, Tejasvi, and Dr. John Runge. And your hosts are Salvanikas, Sembiso Mhanga, and Sibali Gibu. So who are we? We are the GLODEM Training Committee. So it's part of the International Alliance for the Global Health Dermatology under the International Foundation of Dermatology, IFD. Our mission is to promote knowledge equity by enhancing access to dermatological education worldwide. And what we have is educational webinars, which these are free, they're high quality opportunities for learning, networking, and collaborations, which help us to connect all trainees worldwide, as well as we have a podcast series addressing challenges in global health dermatology. So a bit about our meeting etiquette. So all audios will be muted and your camera will be turned off for the duration of all of this webinar. Please submit any question via chat or question and answer function. And our meeting host will share this with the speakers to answer at the end of the webinar. We'll also be sharing further information about the GLODEM Training Committee in the chat function. So I'll say a little bit about our speakers today. So Dr. Tejasvi is a clinical associate professor of dermatology at Michigan Medicine and chief of dermatology services at the VA Ann Arbor Health Care System. He provides expert patient care within our medical dermatology outpatient offices and delivers advances, diagnosis, and treatment of dermatological conditions affecting skin, hair, and nails. Dr. Tejasvi directs the UM Cutaneous Lymphoma Clinic and the teledermatology services. He has clinical and research interest in cutaneous lymphoma, health technology, and skin imaging. He's engaged in studies investigating the clinical and molecular determinants of cutaneous lymphomas, prognosis, and the use of teledermatology and dermoscopy to support cost-saving measures and access to a specialist and improved patient care in underserved areas. Dr. Tejasvi received his medical degree from Karnataka Institute of Medical Science, India. He completed a residence training program and worked as a senior resident in dermatology and venerology at All India Institute of Medical Sciences in New Delhi, India. Dr. Tejasvi completed postdoctoral training in the genetics of psoriasis under the direction of Dr. James T. Elder at the University of Michigan, Department of Dermatology in Ann Arbor. He's active member of many professional, national, and international dermatology associations, including the United States Cutaneous Lymphoma Consortium and the International Society of Cutaneous Lymphoma. We also have Dr. John Runge, MD, PhD, is a third-year dermatology resident at the University of Michigan Medical School. Dr. Runge research focuses on molecular mechanism in dermatological disease with publications in areas such as lymphoma biology and skin cancer. He's actively involved in academic dermatology and community health education. Following residence, Dr. Runge will complete a dermatopathology fellowship at the University of Michigan in 2026 to 2027. So to you, Dr. John Runge, please take over.
Hello, everybody. Thank you very much, Salva. I'm going to pull up my screen here. Hopefully it comes through. Looks like it is. Yeah, really excited to be chatting here today. Thank you, Dr. Tejasvi. We call him Dr. T affectionately, for inviting me to participate in this webinar. The first part of this session will be my component, which is going through some representative cases or some educational cases regarding cutaneous T-cell lymphoma, particularly Mycosis fungoides, which is the most common subtype. And then we'll switch over to Dr. Tejasvi or Dr. T for the remainder of the talk. I don't have any disclosures, and we'll proceed. So to start, the first thing I'd like to do is give a highlight to the Cutaneous Lymphoma Foundation, which I find to be a very excellent um, foundation and resource for patients and providers alike. They have this very helpful website which provides information for patients to understand their diagnoses, which if can be quite complicating to understand. And then there's some patient resources as well, including like handouts for information at um, a non-medical language level to understand the diagnoses further. So with that information out there, just wanted to provide that. We'll go ahead and get started. So the first case we'll be talking about today is a 41-year-old who presented to our clinic with a 10 to 12-year history of a chronic and itching rash. Initially, the rash was only located on the back, but at the time of this initial encounter, it had involved both the anterior and the posterior trunk, as well as the extremities. Previously, before presenting to our clinic, the patient had undergone a biopsy and was informed that the rash was due to eczema, and then had been prescribed triamcinolone cream, but the patient had self-discontinued this because of an associated burning sensation. So when the patient arrived in our clinic, you can see diffuse involvement of the skin by these dark brown, thin, scaly plaques. Some of the areas look a little bit more red, some a little bit slightly more maybe gray to purple. And you can see that there are areas of hypopigmentation as well. And on the far right, you can see there's a circle within that plaque where a biopsy was taken in our clinic. That biopsy from the right thigh came back from our pathology group, described as an atypical epidermotropic T-cell infiltrate. A couple comments here is that they noted the extensive loss of CD7 and diminished intensity of CD5. These are T-cell markers, and when they're lost, that suggests that there is an aberrant population of T-cells. And so they noted that overall the findings are highly concerning for cutaneous T-cell lymphoma. Within the report as well, and upon our discussion with the team, there was a comment that T-cell clonality testing was performed for both T-cell rearrangements in the beta locus and the gamma locus, and these were negative. And then there was next generation sequencing performed of these loci as well. And again, there was no dominant clone identified. So these molecular tests were interpreted as negative. Despite this, overall, based on the histopathology findings, the histopathology was concerning for Mycosis fungoides. So we saw the patient at follow-up, and you can again appreciate that there is a lot of these remainder of the rash. It's very active. This is just a couple of weeks later because we wanted to see the patient again and obtain an additional biopsy. Some additional history was obtained. There were no fevers, no chills, no fatigue, no weight loss. These B symptoms can sometimes be seen in Mycosis fungoides and cutaneous T-cell lymphomas. A CBC with differential was normal, LDH was normal, and a repeat biopsy was obtained from the left thigh. On this biopsy, again, there was a finding of atypical epidermotropic T-cell infiltrate, again concerning for T-cell lymphoma, Mycosis fungoides type. And then they submitted these samples as well for molecular studies to identify clonality. This time, the next generation sequencing of the gamma locus was negative, but of the beta locus of the T-cell receptor was positive. So there was an identification of a positive clone or dominant clone. So at this point, a diagnosis of Mycosis fungoides was able to be rendered, and the patient was started now that we have a definitive diagnosis with narrowband UVB phototherapy 3 times weekly and triamcinolone 0.1. Also, it was ointment that we prescribed rather than cream because the cream can cause discomfort of burning when it's applied. So 6 months after initiating this treatment, we saw the patient in our follow-up, and you can see that the plaques are much improved. There is much less scale. There is post-inflammatory hyperpigmentation, so there's still some discoloration there, but the inflammatory component of the rash is much improved. and the patient's itch had also improved. So one learning point I'd like to make from this case is that in mycosis fungoides and cutaneous T-cell lymphoma, multiple biopsies may be necessary to make the correct diagnosis or to reach the final diagnosis. Here's a similar case that I wanted to draw attention to in less pigmented skin. In this patient, you can see again that there are thin plaques, but in a patient with less pigmented skin, they can look more red. And there's thin scale here. So the learning point from this is that the clinical appearance of cutaneous T-cell lymphoma, like many skin conditions, can vary by skin tone. Transitioning over to a second case now. This patient presented to our clinic about 7 years ago, so that puts us in about 2017. The patient is 56 years old and had presented with 2 to 3 years of itching rash and alopecia. The location of the rash initially when this all began was on the dorsal hands, and then later over time affected the hair-bearing areas of the face. Prior treatment that had been done before the patient arrived in our clinic was he had undergone 2 biopsies by a local dermatologist. These biopsies were re-reviewed at our institution and in summary showed atypical T-cell infiltrates in both. And this infiltrate was folliculocentric, meaning it surrounded the hair follicles. One of the biopsies, not both, but one of the biopsies demonstrated a clonal population by these T-cell receptor rearrangement studies. Again, I'd like to make the point that multiple biopsies may be necessary to make the diagnosis, and I think this is yet another good example of that. Before presenting to our clinic, the patient had been prescribed triamcinolone cream, but self-discontinued also due to a burning sensation. Here's how the patient looked when they came into our clinic. So you can see these erythematous plaques. On the photo on the left, these are involving the hair-bearing area of the face. There's associated alopecia, there is scale, there's a little bit of papillarity to the rash, which is folliculocentric. And you can see the folliculocentricity very well on the right image on the trunk. So on the abdomen, you can see that there are these red papules kind of arranged within a cluster. And each of these erythematous papules are surrounding a hair follicle. Here's a presentation in a couple other areas. The dorsal hands you can see here, a little bit less specific, looks more like conified plaques on the dorsal hands, hard to make out exactly what that may be on clinical presentation alone. And then on the right, you can see that there is a thin, scaly, and eroded plaque on the Mons area. And then again on the inferior abdominal fold there, right about where the hand is that's pulling the skin up, you can see that there are these erythematous papules that are coalescing into a plaque. And each of these, again, is folliculocentric or surrounding a hair follicle. So based on the collection of histopathology, molecular studies, and the clinical presentation, a diagnosis of folliculotropic mycosis fungoides was made. So what we offered the patient was topical steroids, narrowband UVB phototherapy. This ultimately had to be discontinued due to prohibitive travel time, which is often a consideration for these patients because they have to go so frequently, and many of them don't live immediately close to a phototherapy center. And then we had also prescribed bexarotene, a vitamin A analog, which had been at variable doses over time. At a follow-up appointment, almost 2 years ago, about a year and a half ago, the patient presented to our clinic like this. On the left orbit, there is a tumor that is red and purple. On the back of the scalp, again, there is alopecia, there's areas of thick plaques, maybe a couple of tumors there. On the ulnar hand, there is this really large tumor that has purulence associated with it, has a raised edge. And then on the right posterior thigh, again, there's another thick plaque or tumor with areas of ulceration. So we performed a biopsy at this time from the left hand. And in this case, a diagnosis of mycosis fungoides with large cell transformation was made. So one thing I'd like to draw attention to is that overall, and Dr. T will talk about this as well, survival for mycosis fungoides is quite good. On the x-axis here in this plot from Yun Kim many years ago now, you can see that the unit of time where these patients' survival is measured by is in decades. So generally people do quite well. However, there's a subset of patients that do poorly, and the patients that do most poorly are patients with large cell transformation. So in this case, it's very important to recognize it. So we arranged evaluation for systemic treatment with our hem-onc colleagues. We arranged palliative radiation with radiation oncology, and we followed this patient for a long time. And then unfortunately, in the last fall, the patient suffered a stroke, and since that time has been lost to follow-up with specialty providers since. We've placed multiple calls, portal messages, as well as the hem-onc offices and the rad-onc offices have tried to reach out to the patient, but nobody's been able to reach him. So this is concerning, of course, and I think brings us to our final learning point, is that advanced stages of Mycosis Fungoides can be life-threatening. You know, we can't say exactly the patient's status at this time, but he's not been able to follow up. So whether it's related to his stroke, whether it's related to progression of his disease, his health is certainly in question. And so recognizing progression of Mycosis Fungoides, tumors of Mycosis Fungoides, is really important. So that brings me to the end of my portion, and I'll trade off with Dr. T. Thank you.
Thank you. Awesome. So this is University of Michigan, and this is where we are from. And you know, for any successful cutaneous lymphoma program, you need to have. Are you seeing the screen? I'm just. John, are you able to see the screen?
We are, yes.
Okay, perfect. For any successful lymphoma program, you got to have amazing colleagues. And these are my colleagues, Dr. Wilcox, who is our medical oncologist. Cuneo is our radiation oncologist. Dr. Cardi, he's also a medical oncologist. And then Dr. Ristov and Dr. Ross are dermatopathologist and hematopathologist, respectively. And this is our tumor board team. And we function like a well-oiled machine. So if there are any complicated patients, we actually reach out to each other. So these are my disclosures, but it doesn't. It's not relevant to this topic today. So what are we going to do today? So we're going to talk about basics of Mycosis Fungoides. CTCL is a pretty large topic to cover within 20 minutes. So it is a subtype of cutaneous T-cell lymphoma. We'll talk about it. We'll talk about how great masquerader it is. Means like it wears different kinds of masks. We'll talk briefly about staging, and then if I have time, we'll talk about cell of origin, and then I'll give you an overview of the treatments. So sorry for the busy slide. This is the new classification, but all I want you to kind of focus is the top part of it, which is the Mycosis Fungoides, and the agreed clinical variants are follicular tropic Mycosis Fungoides and pagetoid reticulosis and granulomatous slack skin. We won't be having time to discuss about Sézary syndrome today. So Mycosis Fungoides, as I said, it's the most common form. It accounts for 50% of all primary cutaneous lymphomas. It's the most common type of cutaneous T-cell lymphoma. Normally happens around 6th to 7th decade, but can happen in younger patients. More common in men. We've seen early onset in African-American population. Recently, there have been a lot of publications showing development or unmasking of T-cell lymphoma, including Mycosis Fungoides, in patients who have been started for dupilumab, for atopic dermatitis, and other biologics. What are the clinical features, right? So I promise these are the next 2 minutes are the most boring slides because there is a lot of text. So clinical features includes progression through the patch, block, and tumor stages. Then the patch patch stage is where you see irregular erythematous scaly patches occurring in non-sun exposed bathing suit distribution. So most important thing is you have to undress the patient to kind of see non-sun exposed sites, which is very important in diagnosing mycosis fungoides. And the plaque stage, it's more well demarcated, variably shaped violaceous to red-brown plaques, and often they are pruritic. And in the tumor stage, you see rapidly enlarging nodules with frequent ulcerations. And you can see that they arise in the background of patch and plaque lesions. And erythrodermic stage, where you see background erythema in more than 80% of body surface area. Rarely you will see lymph node involvement and visceral involvement. Mycosis fungoides, I want you to keep in mind, is a clinical histopathological correlation is super important. The reason is there are a lot of mimickers which can look like mycosis fungoides, and there are and many times mycosis fungoides can mimic a lot of other cutaneous dermatosis. So I'll show you some examples. So clinical and histopathological correlation is absolutely essential, and that is the if one of them does not agree, then you probably want to biopsy and follow the biology of the disease. So what do you see in histopathology? In patch stage, you see epidermotropic atypical lymphocytes. These atypical lymphocytes are enlarged lymphocytes which have cerebriform nuclei and hyperchromatic nuclei. And predominantly, they are in the epidermis. That's why epidermotropism, and in clusters called as Potrier's microabscesses. And sometimes you can see them lined up at the dermoepidermal junction with clear halos surrounding these cells. You can also see a superficial dermal band-like or a lichenoid lymphocytic infiltrate and wiry fibrosis. In plaque stage, what you see is more prominent epidermotropism with more atypical lymphocytes, and in the dense dermal band of infiltrates. And in tumor stage, you see increased density and depth of dermal infiltrate of atypical lymphocytes with decreased or absent epidermotropism, which is very important. And then and in a special situation where Dr. Runge talked about, which is called as the large cell transformation, it's defined by more than 25% of large cells, which are 4 times the size of a mature lymphocyte. This could be easily identified using a molecular marker CD30, but it doesn't have to be, it is not a prerequisite for making the diagnosis of large cell transformation. We also, wherever there is opportunity, you should do an immunohistochemistry, and it actually helps you to determine what kind of lymphocytes you're seeing. And typically in mycosis fungoides, you see a CD3 positive, CD4 positive, CD8 negative mature T cell lymphocytes. You can also see variable loss of pan-T cell markers, which includes CD7, which is the most common, but it's the least specific. Other markers are CD5 and CD2, and the loss of this are less common, but it's more specific. So whenever there is ambiguous nature, especially in early patch stage disease, you probably want to do a molecular testing for T cell receptor gene rearrangement, which Dr. Runge kind of highlighted. And you got to do multiple biopsies to get the diagnosis of T cell lymphoma. And then hypopigmented mycosis fungoides, which is a variant of it, you usually see a CD4 negative, CD8 positive T cell, and then you see an apoptotic keratinocytes and pigment incontinence, which kind of explains why you develop hypopigmentation. So this is your classic MF. The one on the extreme left is your patch stage disease, where you can see there is mildly erythematous scaly patches. And then you can see this is the plaque stage disease, where you have thick plaques. And then in the background of thick plaques and patches, you see tumor stage. So this is your classic mycosis fungoides, which you need to kind of keep in mind. Okay, looking at this, again, it's kind of really sketchy. It's very interesting that it clinically manifests with sometimes with edge active scaling, And one of the things which you think about when you see this, if you don't train your eyes, if you don't train to kind of have Mycosis fungoides in your differential, is that this mimics Tinea corporis. But you do a KOH prep, and once the KOH prep is negative, you should probably think of doing a biopsy with such extensive annular scaly plaques. Sometimes the scaling can be so thick, and it's involving the follicular part of the face, and especially the eyebrows. You might think that this could be a bad seborrheic dermatitis, or seborrheic or psoriasis in the differential. But again, if they don't respond, and if this is persistent, you probably want to biopsy these, and the biopsy might show Mycosis fungoides. In this case, the biopsy showed Mycosis fungoides. So it's a great masquerader, right? Like you saw from patches to plaques, it can manifest as different kinds of diseases, including like a Tinea corporis versus psoriasis. So in skin of color, it also mimics a lot of conditions. So let's get into that. So why is it important? This is the statistics in the United States. Individuals with African descent have twice the incidence of compared to Northern European descent, though the difference gets the difference decreases with age. Onset of disease may occur at an earlier age, before age 40, and especially has been reported in people of African descent and also women of Hispanic descent. Although the clinical course of Mycosis fungoides progresses slowly, as you saw, it can be life-threatening if it's not recognized early. So, especially in patients of African descent, especially women with early onset disease, have worse prognosis than other groups. So looking at this, what are your differential diagnoses? We might think this could be contact dermatitis just because it's bilaterally symmetrical, right? It could be Tinea cruris because you see that there is annular scaly plaques. In countries where there is leprosy, you have to think about the differential diagnosis of borderline tuberculoid leprosy, as it can closely mimic, and it also affects these double covered areas. So what is one thing which I want you to keep in mind? So you see that these are polychromatic patches or lesions. What do you mean by polychromasia? It means to say that you have hypo, a little bit of hyper, and erythematous area. So combination of these three actually helps you make or suspect the diagnosis of Mycosis fungoides in skin of color. Actually, this was Mycosis fungoides, a classic Mycosis fungoides in skin of color. Again, this is a 65-year-old female with progressive rash. Looking at this is an annular plaque with erythema and margins of scaling. Your differential diagnosis would include Tinea corporis, erythema annularis centrifugum, and even eczematous dermatitis. And places where leprosy is common, it could be like a mid-borderline leprosy with type 1 reaction. But this happened to be Mycosis fungoides. So that's the reason why I wanted to keep in mind that it's a great mimicker or a masquerader of other dermatoses. The reason why I'm showing you this is contrasting between the erythema in this patient is not absolutely appreciated just because the background skin tone, whereas erythema in type 1 to type 3 skin, you can actually appreciate both of them. So both of them are patch blotch stage disease. And when I show this picture, the first thing that comes to your mind is contact dermatitis, especially contact dermatitis to the nickel, right? But when I show you that this patient also had these kind of atrophic hypopigmented patches with some erythema, which again talks about hyperchromasia, right? This is another example of Mycosis fungoides. Sometimes like these can also mimic like infection, especially fungal infections or mycobacterial infection, especially in tumor stages, because they appear so rapidly. And sometimes they also can mimic infections which are similar to dermatosis, like lepromatous leprosy. And when you have such differential, you have to think of what is common in your place, which is like if you're coming from Indian subcontinent or Brazil or Africa, you got to think of infections first. But then when it's not behaving the same way as the infections would behave, you should think Mycosis fungoides in your differential. This is a stage 2B where you see large tumors. There are other variants of Mycosis fungoides. The three recognized variants are follicular tropic Mycosis fungoides. There is syringotropic Mycosis fungoides. Based on the other side, which is the pagetoid reticulosis, granulomatous slack skin. There are other variants called as the poikilodermatous Mycosis fungoides, granulomatous Mycosis fungoides. These are rare forms of Mycosis fungoides, but these are the three which are recognized by the WHO as the variants of Mycosis fungoides. I'll show you some examples. So these are like erythematous thick plaques, and you can actually see in this photograph on the left side where you see follicular prominence. And again, you can appreciate hypo, hyper, and erythematous patches and plaques, which is polychromasia. So this was follicular tropic Mycosis fungoides. This is your classic hypopigmented Mycosis fungoides, and the differential diagnosis here would include early vitiligo, post-Kala-Azar leishmaniasis, even post-inflammatory hypopigmentation as in your differential diagnosis. This is a case of hypopigmented cutaneous T-cell lymphoma. Another case of, this almost looks like a psoriasiform plaque on the legs, and these are, in isolation, you might think that this is psoriasis, or it could be a worse form of eczema in your differential, but then when they are not responding in the same way, you should consider pagetoid reticulosis, which is a rare progressive type of Mycosis fungoides, which looks like a psoriasiform plaque on distal extremities. One of the classical histologic findings which you see is a very prominent epidermotropism in a pagetoid pattern. Normally, they have great prognosis. So either you can treat it with low-dose radiation, or you could do topical medication, and that would clear this up. The other one is the granulomatous slack skin. These, again, I'm trying to show you a contrast between skin of lighter pigmentation, which is type 1 to type 3, whereas compared to skin of color. And these are two variations. So these are extremely rare. They look like sagging skin, kind of sagging skin folds in the axilla and the groin area. And you can see on biopsy granulomatous inflammation with multinucleated giant cells, atypical lymphocytes, and prominent elastophagocytosis, which is the reason why you see saggy skin. Normally follows an indolent course. They usually evolve into classic Mycosis fungoides, and up to 30% of these patients might have developed Hodgkin's lymphoma. Okay, so the first take-home message of this is when you see polychromatic patches and plaques, especially in skin of color, please think of Mycosis fungoides in your differential diagnosis. We follow the NCCN guidelines for diagnosing, for staging Mycosis fungoides and Sézary syndrome. What is very important is these three things which you need to keep in mind. Stage 1, which is T stage, which is the skin involvement. T1 is patches, papules, and plaques, which is less than 10% of the body surface area involvement. T2 disease is, which is patches and plaques, more than 10% body surface area. T1 is basically involvement of the lymph node where the architecture is maintained. And T3 is presence of tumors, mean to say more than 1 centimeter in diameter and should have depth, deeper involvement. And then T4 is confluence of erythema of more than 80%, which is basically erythrodermic disease. I'm not going to be talking about Sézary syndrome, which is stage 4 disease. So based on the body surface area involvement and the nodal and the visceral involvement and the blood involvement, you classify them into clinical stages, which is stage 1A, which is limited skin involvement, stage 1B, skin-only disease, and stage 2 is early lymph node involvement. Stage 2B is tumor stage disease, stage 3A and 3B are erythrodermic disease, and stage 4 is Sézary syndrome. So when somebody comes to my clinic, these are the things which we do. Most important thing is a thorough examination, which should include covered areas. And the assessment important to do is the total body surface area estimation, which could be done by using your patient's palm, which is around 1% BSA. And then you classify what types of lesions they have, whether they have a patch or a plaque or tumor or erythroderma, because these are the most important things which you would document to stage your disease. You should palpate the peripheral lymph node regions, palpate for organomegaly and masses. And then once you've done that, then the other things which you do would be the lab studies, which would be CBC with differential and determination of absolute lymphocyte count. In T2 and T4 stage, T2 to T4 stage skin classification, you can order a flow cytometry. And clonal TCR gene rearrangement in peripheral lymphocytes if blood involvement is suspected. And then you get a comprehensive metabolic panel and LDH. The imaging studies, if patients have T3 or T4, then I would order a PET CT scan or CTs with contrast of chest, abdomen, or pelvis. If you feel lymph nodes and if you think that it's true involvement, then you normally subject them to an excisional or an adequate a core-natal biopsy should be performed. As I said, if there is any change in the clinical phenotype of the disease, then you would offer a rebiopsy if it's suspicious for large cell transformation or follicular tropism. And anytime there is a change in the if there is a change in the type of Mycosis fungoides, then you also order PET CT scan. Offer a pregnancy testing in patients of childbearing potential, and discuss fertility preservation in such patients. For diagnosing it, as I said, clinical and histopathological diagnosis is the most important thing. So multiple biopsies may be necessary to capture the pathological variability of the disease or diagnosis. In patch and plaque stage disease, I would recommend doing a broad shave. And for tumors, you could do either an excisional or a punch biopsy, and that could be adequate. Review of these slides should be done by a pathologist who is well versed with CTCL, because it's really important that they recognize the changes which we see. And so having a dermatopathologist who excels or who is an expert in lymphoma is absolutely essential for your team. And again, we talked about the different things which you do on the IHC panel, which include CD2, CD3, CD4, CD5, 7, 8, 20, and 30. And then you can follow up with the TCR gene rearrangement. In special circumstances, you can get peripheral blood tested for Sézary cells. Why is this important? Like, once the reason why this is important is the staging determines the prognosis, right? So in stage 1A and 1B, which is limited stage, you can see that the prognosis is fantastic. The median overall survival in stage 1 ranges from 20 to 35%, and whereas in the risk of disease progression is really, really small compared to something which is more advanced stage, like the stage 2B to stage 4, which has tumors, erythroderma, node or blood or visceral involvement, which is called the advanced stage. And you can kind of see that it drops down significantly at stage 2B. The overall median overall survival drops down to 4.7, whereas in stage 4B, it's 1.4. And so, and the risk of disease progression in tumor stage is around 60%, whereas the risk of disease progression in Sézary syndrome is around 83 to more than 80%. So why is that important? Because limited stage disease means skin-directed therapies, and advanced stage disease would be systemic monotherapy. I like this slide because, you know, one of the things with my medical oncologist is we always have, what do you guys do? You do lotions, potions, and light, and we are good at that. So still, the first line of treatment is topical steroids. The mechanism of topical steroids is it inhibits lymphocyte binding and induces apoptosis. It has an overall response rate of 95% in stage 1 and 82% in stage 2, with complete remission in 63% of patients of stage 1 and 25% in stage 2. The other skin-targeted therapies for limited stage disease is imiquimod, which is a toll-like receptor agonist, which leads to local production of interferon, TNF-alpha, IL-1, and IL-6, which induces direct tumor cell death and then apoptosis. So overall response rate of these to this was 80%, whereas complete response was seen in 45% in case series which was published. The other similar molecule which has been tested is resiquimod, but this is still in this is just completed phase 1. A newer formulation of meclorethamine gel has been used, or topical nitrogen mustard. The overall response rate is around 60%, and the complete response rate is around 13.8%. So they also saw a sustained response in more than 80% of patients. The most common adverse effects with topical nitrogen mustard or meclorethamine gel is contact dermatitis or irritant dermatitis. There is bexarotene gel, which is a topical RXR, which has an overall response rate between 44 to 63%. And the only issue is the cost toxicity. Even in the United States, it's around $30,000 for a 45-gram tube. Phototherapy is probably the mainstay of treatment for Mycosis fungoides. In type 1 to type 3 skin, I would start with narrowband UVB in T1 and T2 stage disease. In type 4 to 6 skin, PUA would be the first line of treatment. Sometimes we can do combination therapy, and then in stage T4, you can do ECP, which is extracorporeal photopheresis. One of the medications which we do use often here is bexarotene for advanced stage MF, which is stage 1B and beyond. Either as monotherapy or as in combination with light therapy or topical medications, or even with radiation. The way bexarotene works is a selective RXR binding retinoid, affects the cell differentiation and apoptosis, and it downregulates CCR4 and E-selectin expression, and this affects the T cell trafficking to the skin. And the overall response rate is around 45 to 55%. The studies have shown that this has been used from 300 to 650 milligrams in advanced stages. Most of the time, I don't go beyond 300 milligrams per day. This severe side effects are the common side effects are hypertriglyceridemia, hypercholesterolemia, and central hypothyroidism, where we normally kind of start these patients on oral levothyroxine and then fenofibrate for taking care of this hypertriglyceridemia. As I said, often we treat with combination with interferon, ECP, radiation phototherapy. There's been a new molecule called alitretinoin, which binds both RXR and RAR with an overall response rate of 90.5%. This is not available in the United States. Again, the cost toxicity is significant with all of these medications. And then people have also used isotretinoin and acitretin if you don't have other retinoids, if you don't have dexarotene. And the overall response rate ranges from 4 to 67%. So it's kind of it's all over the map. The other systemic agents which could use is the methotrexate at the low dose of 10 to 25 milligrams per week. You start with a test dose and then follow up with a goal dose of 10 to 25 milligrams. And that's another option. And interferon alpha has been used as a second line in stage 1B disease, and they have combined with radiation for better results. The other therapies which have been used is local radiation, which is again low dose, or patients who have extensive involvement. You can even do total skin electron beam therapy, which is again low dose, 10 to 12 grays. And then the total skin electron beam therapy is often combined with maintenance therapies like retinoids and interferon. There are newer systemic agents which are available in the US, but I don't know if it's available in the rest of the world. So brentuximab, which is an anti-CD30 monoclonal antibody, which has been used for severe lymphomatoid papulosis and large cell transformation. Mogamulizumab is an anti-CCR4 monoclonal antibody, and this has been used in Sézary syndrome and erythrodermic CTCL. And HDAC inhibitors have been used for tumor stage mycosis fungoides and Sézary syndrome. And there have been data for pembrolizumab, which is a checkpoint inhibitor in recalcitrant tumor stage MF and Sézary syndrome. And other ones like lactumomab, which is a killer immunoglobulin-like receptor antibody, which has shown that it's effective in 50% of the patients with MF. And there are some data for JAK-STAT pathway. Ruxolitinib has been used in PTCL in phase 3. So what is the take-home message? A thorough clinical examination, including double-covered areas when you suspect Mycosis fungoides. It's especially important with polychromatic patches and plaques. In skin of color, always consider Mycosis fungoides. If you see an erythrodermic patient, consider doing a flow cytometry. Treatment for limited stage disease is skin-directed therapies, and in advanced stage disease, monotherapy systemic agents. There is no role for multi-system chemotherapy, as previously described as CHOP. What the most important thing is patient education regarding what stage they are in and what is the prognosis of their stage and of their disease. And prompt referral to medical oncologists and radiation oncology if you don't have a multidisciplinary tumor board. Again, most important is clinical pathological correlation for diagnosis of Mycosis fungoides, and it's okay to be non-committal of the diagnosis, follow up the patient and reassess and manage according to their biologic behavior. Thank you.
All right, thank you so much to Dr. Tejasvi as well as Dr. Runge. Those was exceptional presentations. So my name is Dr. Semiso Mhlanga, and I'm gonna be just going through the questions that have been raised. So the first question.
Before we jump on, I think we have two questions for the
oh, okay. All right.
Yeah.
Okay. Thank you.
So
thank you.
do you want me to do that? There are only two questions.
Yes, you can proceed with that. You can proceed
Okay.
with that.
So again, I'm kind of beating the horse here. What is the most characteristic feature of Mycosis fungoides in skin of color? I'll give you like 5 seconds. You can put your answers in the chat. Okay, it looks like people are answering answer B, and that is correct. So polychromatic patches and plaques are the most characteristic features of Mycosis fungoides in skin of color. So what is the first line of treatment in limited patch plaque stage of Mycosis fungoides? Give you another 10 seconds to answer the same question. Excellent. Again, I see that people are answering PUVAR, narrowband therapy with skin, phototherapy with skin directed therapy. Correct. So my job is done here. So, so that's my. If you guys want to read more about cutaneous lymphomas, this is my this is the reference. Thank you very much.
Thank you so much. That was very, very comprehensive. Now going back to the questions from Anonymous, who just wants to know which are the clinical and histopathological features that you recommend for clinicians to prioritize for early and accurate diagnosis of MF. We know that it can be a challenge, but which are the pointers clinically and histopathological features? Yeah, so that's any of you, Dr. Runge or yourself, Dr. Tejasvi.
Yeah, I can take it. So clinically, anytime when you see an erythematous patch or plaque with atrophy and scaling is what you should be looking for. And then when you see patch plaque disease, you should do a broad shave biopsy. And in histopathology, you will see epidermotropic atypical lymphocytes, and these lymphocytes have cerebriform and large nuclei in them, and then some of them line against the dermoepidermal junction, and that's your classic stage MF. So that's what I would look for in histopathology, and if you have immunohistochemistry, staining them and looking for what cells they are, which is most of the time it's CD4 positive, and then and if you have another marker to look for is CD7, which is a pan-T cell marker, which is lost in most cases of Mycosis fungoides.
I suppose I might add briefly
Yes.
that like one thing we talk about a lot is eczema that doesn't seem to be responding to eczema directed treatments. You know, that's a good time to reevaluate the diagnosis. Dr. T and I have talked a lot about that, and just wanted to echo everything he's saying.
Thank you. Just while we are still speaking about clinical presentation, there was a question: how do you differentiate vitiligo from hypopigmented MF and other causes of hypopigmentation?
That's a great question. So, so one of the things which you would clinically use is Woods lamp. Most of the time, Woods lamp, the vitiligo will flourish, whereas the hypopigmented MF would not flourish to the extent of vitiligo. So that's one of the important things which you should be looking for. If you kind of use dermatoscope, you can also see there is loss of pigment network completely in vitiligo, whereas in hypopigmented MF, there is lightening or retention of pigment network. And then finally, the classic sites of involvement of vitiligo is a little different than the mycosis fungoides, where most of the time hypopigmented mycosis fungoides affects the double covered area, whereas vitiligo you can see bilaterally symmetrical on elbows, knees, hands, and face. So those are features which you should be thinking of. And if you look at the hair, leukotrichia is present in vitiligo, but no leukotrichia is in hypopigmented mycosis fungoides. I think these are kind of helpful features to differentiate one from the other.
Yeah. Well, thank you so much. And also, I think on presentation as well, Doc, vitiligo will be asymptomatic, but else MF, will be pruritic and that. But no, thank you so much. And there is a question from Dr. Dorothy Soho, who said that she was on light therapy. Is light therapy supposed to bring more patches? Because she started that in December 2024, and she was doing good, but later on started breaking out with more light, having more light sessions, and even when it was reduced, she still had more patches. What's your thoughts around that?
If the person had a great response to light therapy after starting light therapy, probably they are breaking through the disease. The disease is breaking through the treatment, so it's time for you to consider other treatments as light therapy is not sufficient. So that's what my assessment of the condition would be.
Right. No, thank you. And we'll take this one to Dr. Runge. That how do you approach the decision between using a CT imaging versus the whole body PET CT in cases of suspected extracutaneous involvement?
Yeah, thank you for inviting me to answer that question. Probably availability and timing of what can be done. I'll let Dr. T answer too, but PET, we often will prefer PET, but if there's a delay in able to get it done, like the timing is months out based on availability, then whatever you can get done sooner to help get a sense of visceral organ involvement. Dr. T, I'll yield to you for the additional details on that.
I agree with you, John. So basically, it's the matter of availability. If you have a PET CT scan, then it's easier. If you don't have an opportunity to use PET CT scan, then CT with contrast of chest, abdomen, and pelvis should be done.
Thank you. And from Tim Stewart, said the UVB, is it also recommended for follicotropic stage 1A for the treatment of MF?
Was there a question?
Yes. Is it also recommended?
Yes.
UVB for follicotropic MF. Okay, stage 1A. All right.
Yeah, you could use light therapy for any form of MF, even in follicular-tropic MF. Though the efficacy is probably not as good as with the patch block disease. It's just because of the gradient of infiltration of the lymphocytes, because it goes deeper along, which tags along the hair follicle. But in such situations, we do combination treatment with topical steroids or topical meclorhythamine gel with phototherapy, narrowband, or even oral bexarotene would be an option.
Yeah, right. Yeah, just pushing this one. We are out of time. The last one is, how difficult it is to diagnose MF, and now navigating that emotional discussion with patients when you have to take multiple biopsies without yielding any results. Don't know if you have anything to say.
Don, you want to go first?
Sure. I think that's a hard one. It does take many biopsies over many years, and that uncertainty is very hard for individuals suffering with this spectrum of disease. There's cosmesis aspects, you know, if their rash is affecting an area that is on the head and neck or the extremities. And I think that uncertainty is very hard as a provider too. You want to give them the best treatment that they can receive. And if we're not able to wrangle the diagnosis into a category that we find acceptable, then it's very hard. So therapeutic alliance with your patients is something that's super important with these, building that trust, building that relationship to know that you can work together to try to manage the disease as best you can, and working with colleagues who are your teammates to try to come up with the best diagnosis too. I think Dr. T commented on this, is that cutaneous T-cell lymphomas are not a disease that you want to be managing on an island. You know, it involves lots of good relationships with colleagues in different areas to put minds together to come up with the best diagnosis.
Just to add to that, you know, that's the first expectation, which I let patients know, that when we suspect Mycosis fungoides, it would not happen in one biopsy. It might take multiple biopsies to arrive at the diagnosis. Once you set up this expectation to a patient and, you know, proper patient education, it actually helps you. So at the first visit, you got to tell them all of this so that they know that we might be biopsying them multiple times, and that helps.
All right. Well, thank you so much. I'll hand over back to Silva.
Thank you so much, everyone, for today. Thank you to our speakers, Dr. Tejasvi and Dr. Runge. And thank you for all that managed to attend today. So please follow our GLODEM on social media to learn about upcoming events, webinars, and programs, and everything more. We are on Facebook, Instagram, YouTube, and X, formerly known as Twitter. Thank you to our supporters, Tejasvi for Care and Ellis Foundation. Thank you so much all for attending the webinar.
Thanks, Alva.
Bye.
Bye.
Thank you.